So we are live in 5, 4, 3, 2, 1. We are live now.
Okay, thank you.
Okay, thank you.
So welcome to all in the UPOA Friday Musings. Today the topic is the proximal tibial fractures, and we have been regularly done these musings on every Friday. Today's speakers are Dr. Amit Ajgaonkar. Thanks to him for giving consent for to speak in this Friday musing. From Mumbai, Dr. Amit Mishra from Gorakhpur and Dr. Ravi Garg from Kanpur. And we have three panelists. Thank you to Dr. Govind Sethi from UK. He is basically from the Kanpur, settled there. And Dr. Piyush Mishra from Prayagraj and myself. So I request our President, Dr. Ashish, to start this Friday musing.
Thank you, Dr. Santosh. And it's the regular meeting now, and we are having a good amount of learning by this meeting. And I'm grateful to Dr. Amit, Dr. Sethi. Rest of the people are amongst us. So let's go ahead with the academics. Thank you very much.
Hand over to Dr. Girish Dang. He is a moderator of today's Friday musing. Dr. Dang, please.
Thanks, Dr. Santosh Singh. Today, on behalf of the UP Orthopaedic Association, Orthopaedic Club, and myself as President of Orthopaedic Club, I welcome all the esteemed officers of UPOA, Professor Ashish Kumar, President Dr. Anup Agrawal, Secretary Dr. Santosh Singh, and all the esteemed speakers, Dr. Amit Ajgaonkar from Mumbai, Amit Mishra from Gorakhpur, and Dr. Ravi Garg from Kanpur. And the panelists who are consented to be a part of today's initiative of UPOA, Dr. Govind Sethi from UK, Dr. Piyush Mishra from Prayagraj, and Dr. Santosh Singh from Lucknow. I'm also thankful to the OrthoTV team of Dr. Ashok, Shyam, and Dr. Neeraj Bijlani from Mumbai for live streaming this broadcast. Today's topic is proximal tibia fractures, and as everyone knows, these fractures throw up some unique challenges to the orthopedic surgeons. I am hopeful that today's webinar will benefit one and all. I now call upon the first speaker, Dr. Amit Ajgaonkar from Mumbai. He is a well-known speaker in international, national, and state conferences and has conducted numerous hands-on trauma workshops world over. He is having his own specialty hospital at Mumbai. Dr. Amit, please start your presentation.
Yeah, sure. Thank you so much. Thank you for inviting me, Dr. Dang, Dr. Ashish, Dr. Santosh, and my dear friend, Dr. Anup. And I always enjoy being with my UP friends. And as Dr. Ashish said, that I am not amongst you, but I am always there with you. I am amongst the UP people. You are all more friends than the rest of the world. Let me start my presentation. So I share my screen right now. I think all are seeing this.
Yeah.
Yeah. Okay.
Dr. Amit, I am going to mute all so you can unmute yourself.
Yeah. Okay, I have unmuted. I think you all can listen to me.
Yeah.
The posterior fragment. I'm going to talk something about this. Why is this not going ahead? You can see this long time back. Since so many years, we have been treating proximal tibia fractures. When the femur is in the tibia, then and then we have to open the joint. Open the joint with an anterior approach. reflect the patella and get the femur out of the joint. You can see this is a very complicated fracture where there's a depressed element and the femur is into the tibia. Look at the femoral condyle. The CT scan, it is into the femoral condyle is into the tibia. Now, this is fixed with something like this. Many years, I think since the last 5 to 10 years, we have come out with the column concept in the proximal tibia. But before that, we all, in fact, including me, including all the seniors, were fixing, were not having, we didn't understand the proximal tibia, the posterior columns especially. And we used to fix them like this. Here you can see the posterior column, the posteromedial fragment, it is just fixed with a screw. That is not enough. Whenever there is a coronal fracture, you have to go ahead and do a dual plating. Leo has come out with this concept of columns, wherein there is this medial side, lateral side, posterior column is also divided into two, lateral and medial, posteromedial, posterolateral. I think column concept will be spoken by Dr. Amit later on. And but there are a few things over here. So you need to know, because whenever today you're fixing the proximal tibia, you have to take the proximal tibia and divide it into columns. You have to know the morphology, the injury, which column causes what. So generally on the medial side, the varus causes varus plus extension forces. On the medial lateral side, it is the valgus which causes this. And if it is a flexion injury, it is mostly the posterior column. This is probably the most important slide of this talk. The medial condyle is always a concave dish and the lateral is a convex. So whenever the femur hits the medial side divides into two nicely identifiable fragments, which are very, very important. Whereas whenever the femur hits the lateral column, lateral condyle, the lateral condyle shatters. So there's a lot of comminution in the lateral condyle. So whenever you're treating, whenever you're getting x-rays done, the lateral condyle is comminuted most of the times and the medial condyle is a better condyle. Medial condyle preserves the anatomic landmarks. The fracture reduction begins medially, always. Medial condyle should be addressed first and anatomically reduced because it's a better condyle. Look over here, you can see the medial condyle. It's a good condyle divided into good, nicely identifiable halves by the coronal fracture. Whereas on the lateral side, there's all comminution. Very difficult to get the lateral condyle into a good anatomic reduction, but you can just elevate whatever is depressed, look out for the posterior fragments and fix it. Now, this is another important slide. Whenever you have a fracture, a plate to be put on this side of this posterior surface, you have to take the patient in a prone position. Posterior or posteromedial approach. Whenever you have to put a plate over here, it is a supine position with a figure of 4. And here, that's a posterolateral. Then again, it is a prone. Transfibular, there are numerous approaches. It could be a transfibular, it could be another approach wherein you go through the soleus muscle. Now let's talk about the posteromedial approach. It is in the supine position. You are fixing the posteromedial fragment and here you just go supine. Take care of your saphenous nerve. The skin incision lies over there. It is a crease which divides your pes anserinus and the medial head of the gastrocnemius. Exposure of the pes anserinus by retracting the saphenous vein and nerve anteriorly and the gastrocnemius, the medial head, posteriorly. Supine position, there you can see the fracture fragments. Retract the pes anteriorly without detaching and mobilize the gastrocnemius. If at all, once you see the fracture gets reduced in the knee extended position. Mind you, you are in a figure of 4. The figure of 4 is a flexed position. The fracture is going to get reduced in the extended position. So if you get it back into the extended position, you can see over here, the reduction will be lost. So what you need to do is you have to hold your fracture fragments with either K-wires and then put a plate in the flexed position So hold your fracture with KOLs, put a plate in the flex position. You have to see to it that the apex matches. So this apex should match. This is the way you put the plate. This is a buttressing plate, and the screw should be, this is the screw, first screw which is below the apex, and this should buttress the plate against the fracture. In fact, this sort of fixation is also good enough. You may then later on add unicortical screws up and down to this fixation. Once you do this, then go ahead and complete your fixation with a lateral plate. Now look over here, you can see the fracture is fixed, the apex is matching each other, and the plate is put properly. What happens if your apex is comminuted? If your apex of the fracture is comminuted, you have to just go on the V of the fracture, not the tip apex. On the V should match. Even if the V is not matching, it means you're not getting a reduction intra-articular. If your apex is matching, your intra-articular reduction is good enough. If that is so, your intra-articular reduction will be lost. And this is the most important condyle, the medial condyle, the beta condyle. You have to reduce it from intra-articular also. Slightest of doubt, go down, open the joint, get a submeniscal incision or arthroscopically from the anteromedial portal from where you opened, go submeniscal, take a stitch in your meniscus, just elevate your meniscus, and you'll be able to see the joint properly once you give a slight valgus force. So once you're down there, you have fixed your the posterior plate, then you go and fix your lateral plate. Mind you, just imagine if you're not put your posterior medial plate and just a lateral plate, your lateral plate will have one screw into the posterior medial fragment of the posterior condyle. So that may cause a displacement of your posterior condyle if you have not fixed your posterior condyle well. Distraction at the fracture site. So first is your posterior condyle, then your lateral plate. Here, this is your plate. So this was the failed fixation. You have to go down, and you have to go down properly, and you have to put a posterior medial plate and come out. Never hesitate to go posterior. Sometimes posterior medial is always not enough. So you have to go down prone, and there, totally, completely prone, you have to expose this portion. How will you do that? This is the prone position, and here the Shyam lateral view is taken in this way because you have to add certain things just below it. You may put a pillows, or you may put some something to elevate your leg, and your other leg should be slightly below so that your lateral view is taken in this fashion. The other leg does not come in the way of the lateral view. This is the incision. Now this S incision is not needed mostly. It is this inverted L-shaped incision which is easily taken, and you have to expose your medial gastrocnemius. This is the posterior side anatomy, and here you take that inverted L incision, and once you do that, you see your medial head. This is the big medial head which is seen, and this is the pes, and you have to retract the medial head. You can easily go down. If at all you want to go more medially, more laterally, then you can just release some fibers of the gastrocnemius medial head from the femoral attachment. Once you do that, the medial head of the gastrocnemius relaxes, and you can retract it. And here you can see this fragment. This fragment, the apex is bang posterior. You have to go down posteriorly and put a posterior plate. And this is the way. From this incision, if you just extend it into a S, you can go down more laterally also. If you extend this incision and then you retract the lateral gastrocnemius on the medial side, you can take another submuscular approach, intermuscular approach, and go down and put a small oblique plate on the posterolateral side also. So mind you, this is a very easy approach to put your posteromedial, bang posterior, and a small posterolateral plate also. So here this was done, and look at this fracture fragment. This is the CT which was done, and here we are on it, and this is the plate put. How well the posterior condyle is fixed, and this is a single plate on the posterior side. Later on, a lateral plate was added, and here this is a final fixation. How well it has been fixed, you can really see that. Look at this fracture. Now here it is fracture which is extending posteriorly, and this is a posterior extension and this flush approach. This approach is a posterolateral approach. You are banged down on the, if you have a posterolateral fragment, bang down on the medial border of the fibula, go down on the medial border of the fibula, retract your lateral head. This is the lateral head of the gastro. Identify your common peroneal nerve first, then go down, retract your popliteus muscle. You're down on the soleus, and once you're down on the soleus, you just cut upon the soleus. You will find your genicular artery over there, inferior genicular. You have to ligate, and then you can put a small plate up till your around 5 centimeters to 6 centimeters from the joint line. And this is the way you do it. This is a common peroneal nerve. You go down, you elevate it. A small plate is put on the posterolateral side. This is a slightly difficult because the tibia, whenever you open it from the posterior side, the tibia is more anterior and the fibula is posterior. So first, you might feel that you are on the fibula. The fibula is the tibia. So you have to identify the fibula first. Go down, take care of your common peroneal nerve, take care of the arteries, the genicular artery, and also the popliteal artery, which enters into the interosseous membrane and which divides the anterior tibial artery. And you have to take care of that artery and put this posterolateral plate. Here, this is the patient where we have put these plates. So in and all, if you compare congruity, stability, and alignment, if you compare acetabulum to a tibial plateau, in an acetabulum, the congruity, that is the joint congruity, is the most important thing. And the alignment and stability comes later. Whereas in tibial plateau, your alignment and stability are the most, you have to give priority to your alignment and stability rather than the joint congruity. You have to align the joint well. But look, the lateral condyle, which is comminuted, you will never be able to get a proper alignment of that articular surface, which is always okay. So tibial plateau for an intra-articular reduction is slightly forgiving. As it is so many years, we all have been operating tibial plateau fractures. And without the knowledge of the posterior fragment, now our knowledge has been filtered to the posterior plating and the posterior fragment. All the patients used to do pretty okay. Now our patients are being better managed by the identification of the posterior fragment and the approaches to the posterior fixation. So mind you, on the tibial plateau, while fixing your tibial plateau, take care of the stability and the alignment of the tibia. That is most important. Thank you.
Thank you, Dr. Amit. Very precise presentation and very basic, which we have to know in every case. Dr. Dang, sir, are you here? Dr. Girish Dang, sir, unmute yourself.
Okay. Thank you, Dr. Amit, for such a nice presentation. We will be taking questions from the panelists and the audiences at the end of each presentation. Any questions, please, from the panelists?
Yeah, I think Dr. Amit, excellent talk. I think things have really changed since we used to do tibial plateau fracture in the past. Lateral plating, medial plating is not all we used to do with L plates or T plates, if you remember, the eosynthese.
Yes.
And also we used to put some 4.5 millimeter screws. They were bulky enough and they used to have some concerns. And things have really changed over the period of time. And now we know the column theory, and that has really helped us to get a better outcome. I think overall, I think the best thing what we see is the posteromedial. That is so important. And in the past, if you remember, we were looking into getting the articular surface, and you rightly said, what we're trying to achieve is stability and getting a bone stock. If we don't get the bone stock available, things going to fail later, even for the future surgery in the years to come. So we need to get the bone stock. One question I want to ask you with the posture, sometimes you get a short skirt fall in which you feel that the fracture goes just more lateral to the tibial spine. And what happens if the tibial spine is also avulsed with a fracture? That is something, how do you address that? I find it difficult. Should we leave it for a later day? And get your medial and lateral column, get your bone, and leave it for the later day. If patient has a symptomatic of instability because of ACL, and then we act accordingly, or should we address at the same time?
For me, I think such fractures are very commonly seen in our routine practice. It's a very good question, sir, because we have all discussed about this tibial spine and ACL avulsions in proximal tibia fractures. There are a few people of the opinion to fix primarily if you are opening the joint, if at all. But if not, generally while fixing the proximal tibia, we do not open the joints. So if not, then what I believe in whatever patients I have done, I have left the tibial spine alone because there is a lot of combination, and when there is a combination, it generally unites. Most of the time, it takes care of its own union properly, and then later on, there's no question. But whenever I'm treating a patient for the first time, and if there is an ACL avulsion found, I always tell the patient that he might require a surgery later on, which 90% of the times he does not. He does not require, because most of the fracture unites. It's a bony avulsion. This is not an intra-substance avulsion of tear. So it generally unites. So you have to concentrate on your proximal tibia fixation properly, get a good alignment, get a good stability, and there you are. Within 2-3 months of fracture unites.
I'll probably go with you as well, because I find there's so much to do at the same time, and trying to fiddle with that will probably jeopardize your already primary fixation.
Absolutely right.
And you're right that most of the patients, this being a bony avulsion, you may have some laxity, but not instability of an ACL.
Correct.
You may feel your draw test is positive, but you may not have instability. So we can deal with it later. That's true. Yeah, and also one thing you mentioned was about this, which was very good, was a fresh approach of the fibula. That's a wonderful approach. But the only thing people have to be concerned about, as you said, oblique plates. Don't go too down, because you're going to hit the popliteal artery going into an anterior tibial artery, and that is where you get a problem. So, but that is a few things we need to be careful about. But I think it's quite good. And the plates have become smaller. Don't have to put 4.5 now. You can get 3.5. Smaller plates have become more in fashion, because what you're needing is buttressing. You're buttressing, getting your bone stock, getting your alignment. And the other thing which I feel is sometimes because you don't open the joint, the appearance you mentioned with the convexity and the concavity, the lateral condyle is always proximal. It's higher up. If you're not getting it right with your X-ray at the same time, make sure if your lateral plateau is not higher than the medial, you're not still reduced it. So over reduce it.
Right. Yeah.
Thank you, Dr. Amit. Nice presentation. One question: how you manage the compound injuries in this upper tibia? Most of the time, it is compound in roadside injuries. How you manage this, or what is your experience with Elizarov in these cases?
Piyush, I think Elizarovs I generally avoid Elizarovs in these fractures. Compound injuries, I do get patients, but then they are grade 1 compound, and whenever there is a grade 1 or grade 2 compound injuries, the primary hematoma is lost. So you have to wait. I put external fixators. As it is, whenever I'm not talked about it, whenever there is swelling, I put an external fixator, wait for a reduction of the swelling, wait for the fracture to get quiescent, for the wrinkle sign to appear. Once that appears, then you go ahead with the fixation after a few days. It takes around 10 to 12 days. In compound fractures, as it is, you have to put a fixator and manage your compound injury. In a primary compound injury, when we are not going to operate this, if this fracture is never operated primarily. So even in a compound injury, you have to put an external fixator and then go ahead with the secondary final fixation after the stability and after your swelling reduces, after infection also is under control.
There's an old dictum, span, scan, plan. Span it, scan it, plan it. So for this.
Yeah, correct.
Thank you, Dr. Amit.
Yes, Dr. Girish Dang, move forward.
Thank you for such a lively discussion. Our next speaker is Dr. Amit Mishra from Gorakhpur. He is Professor, Department of Orthopedics, BRD Medical College, Gorakhpur. He is Orthoscopy Unit in charge there. He has 12 research publications in national journals. He will be speaking on 3-column fixation for complex tibial plateau fractures. Dr. Amit Mishra, please start your presentation.
Sharing
Thank
my
you.
slides. My slides are visible.
Yes.
Do my slides are visible, sir?
Yes, yes. Go forward.
Thank you, sir. I am presenting the 3-column fixation for complex tibial plateau fractures. In general, sciatica type 4 to type 6 are considered as a complex tibial plateau fractures, although it does not have fractures of high energy. This is an overview of tibial plateau. Tibial plateau is the proximal end, including the metaphysis, the epiphyseal region, as well as the articular surface. AO defines tibial plateau as a metaphysis distance equal to the width of the proximal part. Tibial plateau fractures are usually lateral plateau fractures. It constitutes around 55 to 70% of the all fractures. Medial tibial plateau fractures, it constitutes around 10 to 25%. And type 4 and type 5 and type 6 fractures, bicondylar fractures are 10 to 25%. The anatomy, medial tibial plateau, lateral tibial plateau, I think all we know. The medial tibial plateau is concave, as Dr. Amit Ajgaonkar sir has told us about the sign of convexity and concavity. Usually the mechanism of injury is force directed medially valgus force or laterally varus force. Is both it leads to the split fractures with the injuries of the collaterals. The axial compressive forces leads to the depression of the articular surface, and both axial forces and the force from the side leads to the split and depression. There are different classification which defines on the tibial plateau fractures: Hole and Moore classification, AO classification, 3-column classification, Dupré classification, and most commonly we read about the Shatzer classification. I am today focusing on the 3-column classification. What is our aim of treating a tibial plateau fracture? The aim is an anatomical reduction, maintenance of the axial alignment, and the stable fixation, which allow us a early rehabilitation and improved functional outcome. The 3-column concept is the tibial plateau is divided into the medial and lateral columns along with the posterior columns. Further, the posterior column is also divided into posterior-medial and posterior-lateral column. This is an overview of the columns. One column fracture is defined as a independent articular depression which with break of column is defined as the fracture of relative column. Pure articular depression, usually in sciatica type 3, is defined as a 0-column fracture. Anterolateral fracture and a separate posterior lateral articular depression with the break of the posterior wall. The fracture is defined as a 2-column fracture, lateral and the posterior column fractures. Anteromedial plus posteromedial fractures are also defined as a 2-column fractures. The 3-column fracture is defined as at least one independent articular fragment in each of the columns, 3 columns. This is one column fracture, pure cleavage of the fracture of the lateral tibial to type 2 Schatzker is also one column fracture, one column posterior fracture, posterior column fragment with the involvement of the medial or the anteromedial or the anterolateral column, which is not included in the Schatzker classification. Zero columns are type 3A and zero column type 3B. Schatzker is also defined as zero column fracture. Two column medial and posterior column is defined as in Schatzker as type 4 medial tibial plateau fracture with a separate split or depressed components. Two column lateral and posterior, which is not included in the Schatzker, is a lateral tibial plateau fracture with a separate split and depressed component of the lateral column. Three column, the Schatzker type 5, type 6 are included in a three column fractures. Type 5, the wedge fractures of the lateral and the medial plateau. Type 6, a variable bicondylar fracture pattern with transverse subcondylar fracture and dissociation of the metaphysis and diaphysis. And three column, third posterior column component is not included in the Schatzker classification. So this is how it is different from the Schatzker classification. I am presenting some cases. This is a tibial plateau fracture with the split of the lateral column and the posterior column. This is a MRI we have, which is showing the columns, the posterior and the lateral columns are broken and depressed. We treated this fracture with a posteromedial plate and an anterolateral plate along with the anteromedial plate. All three plates are used simultaneously in a single sitting. And after the union, the clinical presentation of the patient is like this. He has a good flexion, good extension. Patient can sit cross-legged comfortably. Another case, a 30-year-old male with a Schatzker type 6, which is showing this is something like three column burst fracture, you can say. Both the posterior column, the anteromedial and anterolateral column, all the three columns are broken with avulsion of the eminence, tibial eminence also. This is fixed with the posterior plate, medial. All these the plates we use are the simple reconstruction plates, which are low profile plates, and the anterolateral plate. Another case, it is a patient with a Schatzker type 6 on, and in this also all the three columns are fractured. There is a posterior fragment. This is the complete posteromedial fragment with the lateral fragment. This is also fixed. Initially, the posterior fragment is fixed, posteromedial, and later on the anterolateral plate is applied. This is also a three column fracture. It's Schatzker type 6. In this, all the three columns ruptured. I think the MRI is not there. MRI or CT was not there of this patient. And this patient, this is fixed with a ref plate and a posterior medial plate. And in this patient, we had also fixed the fibular head also. This is a injury, the translation type injury, Scherzinger type 5. The columns are not depressed, but we use here also use a posterior plate and a posterior medial and an anterolateral plate. Thank you, sir.
Stop sharing your screen.
Thank you. Thank you, Dr. Amit Mishra,
Thank you, sir.
for such a nice presentation. We will be taking questions from the audiences and the panelists. Any questions, please?
Dr. Amit, you have done the case 1. So you have applied 3 plates in a single sitting, and how many approaches you used for that fixation of the 3 columns?
Usually we use 2 approaches, the posterior approach with which we use the posterior and the posterior medial plate, and an approach, the minimally invasive approach for the lateral fixation, for the lateral plate. So 2 incision we use.
In a same sitting?
Same sitting, sir. Same sitting.
And
First,
you have applied all the plates ended at the same level.
So exactly they are not at the same level. 1 or 2 holes are up and down, but we have not used a very long plate in any of our fractures, and we are getting the proper result because we are fixing the metaphyseal region, and with the because the fixation is usually three-dimensional with all the 3 plates. It is good to we use the plates, 1 long plate usually in a lateral side, but we are getting the proper results with these fixations.
Dr. Amit, the tibial condyle width, the width of the tibial condyle should match the femoral condyle while after fixation. So many a times what happens, we wait in these fractures, intra-articular fractures, intra-articular splits, we wait for around 10 days or a week's time. And after that, it's a bit difficult getting the condylar width back. While fixation, to get the condylar width, the lateral femoral condyle and the medial femoral condyle should match the tibial condyles on both the sides after fixation. So have you realized, did you have any problems while doing that? And if at all there is a tibial width problem, how do you get it back to its normal position?
So usually these type 5, type 6 fractures are usually the burst fractures. Everything is जैसे मतलब कुछ फटा हुआ सा हिस्सा रहता है और the fragments are very small. Exactly getting the proper alignment of the lateral and the medial femoral and the lateral and medial tibial condyles are little difficult, but because we accept some gap or because these are the cancellous bones and they unite well, so they do
unite well, but then your stability depends upon your collaterals. If your collaterals are matching, if your femoral and lateral, the tibial condyles are matching properly, then that means you have maintained your stability well. What I generally do is, I'll tell you, I hold it with tongs, with patella holding forceps. Even if it does not, many a times what happens, there is a meniscus which is there, tone meniscus, which is there inside the fragments, which has gone inside the tibial condyle fragments. So you need to identify that. benefit of doubt should be there, and then you have to open it, get your meniscus out of your tibial condyle. That does not allow your tibial condyles to come back in its normal position. And the third thing is, if there's no meniscus, even if you're not getting it with a patellar holding forceps, then while putting your lateral plate, or because the lateral plate is the one which will get your condyles together, your screws will go bicondylar, bicortical. So what I do is I put cortical screws, 3.5 cortical screws sometimes, to get a good fixation, to get an alignment of the opposite fragment. So the condyles, but somehow the tibial condyles, many a times, as you said, you are right, they do not match properly later on. So that gives rise to some amount of instability in these fractures. We need to see through it that the femoral and tibial condyles match properly.
Thank you, Dr. Amit, for nice presentation.
The cortical screws, do you get the hold on the proximal?
No. I just put temporary cortical screws and then put the locking screws, and then again remove those cortical screws once I've got my condylar width properly. You know, the cortical screws will get a good hold on the opposite side and good compression.
Thank you.
Thank you, Dr. Amit. There's one question. How you address the ligamentous injury or collateral injury associated with these fractures?
So you see that most of the time we are having with MRIs. We are getting MRI of all our patients. So if at all, if there is any, we are mostly addressing the medial collateral injuries. If MCL is there, we definitely going to repair them, or if needed, reconstruct them. And because most of the time there is a fibular head fracture, so we cannot able to assess properly what is the status of LCL. If there is torn LCL, then we wait for some time, all the fractures united. After that, if any instability occurs, so those instabilities should be addressed. Most of the time you see that with these patients, you have some limited range of motion, because if the patients come with this type of fracture type, Schatzker type, we have 5, 6, 3 column fractures, they usually have some terminal restriction of movements. So at that time, the ligamentous instability is not so much of concern if the patient is having a limited range of motion. If patient is having a good range of motion, then ligamentous instability must be addressed, but on later phase. As Dr. Amit had said, that the avulsion of ACL or these things usually unite with the time passes, and we don't get so much of instability ACL anterior drawer or Lachman positive after 8 weeks, 9 weeks after the fractures. It is also due to some restriction of the movements.
Okay, Dr. Amit.
Thank you, Dr. Amit, for very nice presentation and such a lively discussion. Our next speaker is Dr. Ravi Garg from Kanpur. He passed his MBBS and MS Orthopaedics from GSVM Medical College, Kanpur. He is Associate Professor, GSVM Medical College, Kanpur. Besides running his own Garg Orthopedics and Arthritis Center at Kanpur. Dr. Garg, please start your presentation. Thank you.
Dr. Amit, Dr. Ravi, unmute yourself.
Yes, no voice.
Dr. Ravi, yes.
Good evening, all of you. Dr. Santosh Singh, Secretary UPA, President Dr. Ashish, Dr. Anup, Dr. Girish, Dr. Piyush, and of course, Dr. Govind Sethi from UK. He's passed from the GSV Medical College, done MS from here, our own institution. So the today topic is that the proximal tibial fractures. My presentation is simple case, young male sustained road traffic accident, and there is a split depressed fracture and the lateral tibial condyle. It's Surgery type 2. So in this case, type 2 split depressed fracture, we have to see where is the depression to do the CT and the CT scan on the coronal section, on sagittal section. You have to find where is the depression, either one depression, contained or not contained. So you have to see CT scan very carefully, because you have to elevate that depressed segment by elevator or something else. So you have to see that this 3D CT scan or this axial session, where is the depression. In this case, there is a 2 depression on axial view. This is anterior and posterior on this lateral tibial plateau. So CT is very important. So how to elevate this depressed segment? With the help of CT scan, we can elevate this depressed segment. We can locate this depressed segment, and we can elevate this depressed segment either from the medial side, making a bone tunnel on the medial side, and introduce a punch to this depressed segment and slightly elevate this depressed segment, or by making a hinge on the split part, and we can locate that depressed segment directly on this lateral approach, and we can elevate this depressed segment by hinging the split part of the tibial plateau. So how we assess this depressed segment is elevated. So for that, we have to do submeniscus arthrotomy is there. Submeniscal arthrotomy is very important in split depressed fracture, type 2 fracture of lateral tibial condyle. We have to cut the meniscus from the anterior to, of course, this posterolateral part, and we have lifted this meniscus part by ethibond, and there's apply over this fracture on the Barrett's force is there. So we open the joint on lateral surface. So we could see that depressed segment anatomically, which position is there, and while elevating this depressed segment, we can see the reduction is perfect or not. After we elevating these segments from this elevator from the middle side or lateral side, we can fix this segment either by K-wire, or we can fix this segment by separate screw 3.5 and check anatomically and Shyam by Shyam radiologically that this segment is reduced or not reduced. And after this segment fixation or temporary fixation by K-wire, we can apply the buttress plating by rasp plating. Usually prefer the rasp plating because we have to rasp these segments, these depressed segments anatomically by 4 screw from anterior to posterior. So we can rasp this segment, and you see that this is nicely rasping this screw by rasp plate 3.5 rasp plate, and you can see this by bead. We can by doing this submeniscal arthrotomy, we can see this depressed segment is elevated. This is the depressed segment. I think video has some problem. You can see in this picture, this is the depressed segment which is elevated by elevator or punch from the middle side, and you can easily visualize these depressed segment on the lateral tibial condyle by elevating this meniscus by ethibond, and we can cut the meniscus submeniscal arthrotomy from the anterior side anterolateral to that posterolateral circumferentially, and this elevated. After fixing this segment or wrap the plate. You can stitch back this meniscus to the peripheral rim. And by this, you can fix the no. Thank you, sir. This is a short presentation of this depressed lateral tibial plateau fracture.
Dr. Ravi, have you filled up the void below the depressed fracture?
Yes, sir.
Have you filled out the void which is
No, sir. I usually not fill these voids usually because
you're not afraid of the fragments going back to their status quo position again getting depressed later on after your fixation, because there might be small fragments. Even if you put a raft plate, small fragments generally go between the raft and then they sink between the two screws.
You can fix this small segment by the separate screw or the 2.5 or 3.5 screw. Or
no, I'm talking about the elevated fragments. If there is a combination and you have elevated, then you have put a raft plate with 3-4 raft screws, and then the elevated fragments, if you have not put any, like Dr. Santosh has talked about, some filling the void with strut or something else, then those small fragments can get depressed in between the screws. They can come between the screws and come down again and get depressed.
And even sometime it tilted towards the gap.
Yeah.
And the one side is supported by the screw, but other side is tilted again. So I always do the filling of that portion, either by the chronos or by the graft. If we need the more amount, then we need we use a graft. Otherwise, with the chronos.
I think the small fragment should be avoided for any void or graft. But in case of the large fragment, if a large void is there, you can fill that void by a artificial bone substitute or by the bone graft. But in a small depressed fragment, usually avoid this graft or void. Doctor,
it is very well said that these voids do not need to be filled. But then there is always that fear that it might go back to its original position, and then the fragment can sink.
So we can fix if there is a subchondral fragment, so we can fix this fragment by a separate screw. So
it is not possible. It is not possible.
Yeah, it's not possible.
I think there's another good guide is if you are an arthroscopist for pure depressed, I'm talking about pure cleavage depressed fracture. If you're something who deals with arthroscopy and do ACL reconstruction, you can use an ACL guide, okay? Use an ACL guide and put the pointer where you normally drill it. So you know where you have to make a small operculum and you can drill it and then start packing it from below. In that case, you can also scope and see you have to over reduce it. And that in that case, you're not making big holes as well. So you know where the depression is, the pointer is there. For people who do ACL reconstruction, they drill it to get their tendon into that, In that case, you can use whatever device you choose to use, McDonald or any impactor. But I do believe we have to add something. No doubt it has changed from bone grafting to bone substitute. That is definitely a bit of a change there over the period of time. And I think that's one thing I would say for sure. And also, Dr. Amit, I think sometimes there's a bit of difference how you manage these fractures in elderly age group. You see, patient who got osteoarthritic knees, and when they develop or when they have got this fractures of plateau fractures, how do you manage it? Do you always try to go in and fix them? But naturally, if they're big depression, you don't need to do anything. But if they have got minimal depression, how do you deal with those?
This problem always arises if at all you have an established osteoarthritis, a tricompartmental osteoarthritis in an elderly. Then there are a few cases, not many, but I've done I've done straight away a TKR in these cases using a long tibial rod. So they have really done well, because if at all there's an arthritis, the patient's pain is not going to go. Plus the stability is a factor where even if you get your fracture united, I think it is a better result would be with the TKR.
Yeah, I think you're right, because since we start getting our cones, the cones we get for the TKRs, but the important thing is CT scan, we need to make sure a cone is not a solution for all the fractures of the tibial plateau. Correct. If they're too lower down, then avoid it. What we are tending to do is, naturally, if there is a significant bone loss, especially, then we do try to elevate. Otherwise, what we started doing is putting the patient into plaster only for 2 weeks. Provided, there's not significant bone loss, put them into a hinged brace, not plaster brace, hinged brace. They don't take it off, and let them start mobilizing their knee so as to form like a bag of bone, and let them take its course till the fracture unites, and then do a TKR later. So, but again, this is not a blank statement that everybody will get the same treatment. But the important thing is, especially the lateral plateau, we can treat still more conservatively, but not the medial. The varus is not acceptable. The varus, when the fracture goes into varus, not acceptable. Lateral tibial plateau, you can still, if they're not significantly depressed, treat them conservatively, but on the basis, they can afford totally and so on. So I think they're slightly different how we manage the elderly osteoarthritic. And also, when you get on a CT scan, the posterolateral fragment, even if it's a column fracture, if it's not depressed, even for young adults, you fix whatever the column is. If it's not depressed, you can leave it not to fix it, because your upper end of the fibula is acting at a buttress. You're not weight bearing them, provided it's not depressed. Again, I would say. So you have to fix the posteromedial is most important. And posterolateral, if it's not depressed, if it's a column, you don't have to fix that. You fix all the column, leave it, and don't let them weight bear for about 6 weeks or so.
One point you very well made is that your posterior, if your intact fibula acts as a buttress and it's a support to the posterolateral fragment. If your fibula is intact proximally, then you may not need a posterolateral fixation. Your posteromedial fixation is always good enough to get a good stability and alignment of your fracture.
And also with the medial, the biggest problem is the medial. If you look into the important thing is, if you got Shaskar 4, 5, or 6, start looking for vascular problem. Think there is, you need to exclude it, because Shaskar 4 is the most dangerous, more than 5 and 6. I would say. Yeah. So Shaskar 4, because of the vascular. And if you see, always the femur goes with the tibia, with the medial. It doesn't go with the lateral. And as Dr. Amit was saying, the broadening is also, I think we should not accept broadening around the medial side, but the lateral side a bit can be accepted, because when you pack the graft, then normally you will need more than what you think about, you see. But yes, the posteromedial, again, posteromedial has become the most important amongst all the columns to be fixed.
Right.
Thank you, Dr. Sethi, for giving the tips, very useful tips. So, Dr. Girish Dang, sir.
Thank you. At the end, I would like to thank the UP Orthopaedic Association, the esteemed speakers, Dr. Amit Ajgaonkar from Mumbai, Dr. Amit Mishra from Gorakhpur, Dr. Ravi from Kanpur, all the panelists, Dr. Govind Sethi from UK, Dr. Piyush Mishra from Prayagraj, and Dr. Santosh Singh from Lucknow, and the OrthoTV team for live streaming this broadcast. Thank you, everyone,
Thank you.
and good night. Thank you.
Thank you very much. Thank you, sir.
Thank you.
Thank you.
Thank you. Good night.
Thank you. Thank you.
Thank you, sir.
Good night, everybody. Thank you.
Good night. Please stop the